probably be a bit of alcohol and a little bit of violence. I don't think there's any drugs in this. So it's a real pleasure to talk here, and I'm going to do a bit about mainly this, which is nationally focused, globally responsible, which is our international strategy, and draw on that. And I'll do a little bit of more specific stuff, drawing some examples from that and the sorts of work, particularly me and other members of the team have been involved in. And we have a great international team: Mariana, Lauren, Elodie, Olga, Anna, who work within the IHCC, within the Public Health, the Policy Research and International Development Division in Public Health Wales. So a little bit of general. I've also been told that we're late for lunch, so I should go at whatever pace is possible through this. So just to give you an example here, these little, if you can see them, these little arrows just give you examples globally of places which Public Health Wales is involved in terms of projects. And there are considerable numbers even in Africa, obviously many more in Europe, and of course it's not going to be possible to go through all those. The IHCC, who are the co-hosts here, I understand, a collaborating centre, and they have a specific set of roles, so a focal point for the knowledge exchange and networking across Wales on an international basis, facilitating international collaboration and partnership building and networks, and looking at income as well, reducing duplication of efforts, so some common sense things, maximising potential gains to Wales, it's important. It's that quid pro quo as well, which is really important. And things which have just been mentioned in the questions, like the Charter for International Health Partnerships in Wales, a great initiative about getting the roles, responsibility, and if you like, rules in place, and all health boards signed up to, in terms of how we work on an international basis. Most people in the room will be familiar with that. It was launched some years ago, and it's been celebrated a couple of times as progress has gone on. But looking at organisational responsibilities, reciprocal partnership working, good practice and sound governance. And you can see some of these here, so making sure you've got a contact point in each organisation. Making all partnerships based on mutual respect. So again, making sure that we've got that two-way movement. And we heard that in the Ebola talks as well, about making sure that that's in place. And monitoring the cost effectiveness and efficiency of international partnerships. So making sure we're actually accomplishing something is critical with what are very limited resources, and also identifying other opportunities for resources, amongst many other issues, so that we can build on successes where we know we've had success. The international strategy covers 10 years, and we're about to move into a 10-year strategy for the whole of Public Health Wales, and planning that at the moment. This here is, I imagine, far too complicated and far too small for people to see, but it takes us from, on the top here, from an umbrella at the bottom with Wales, all the way up to the Sustainable Development Goals, going through things like the European frameworks to other areas. But within it, we've got key strategic priorities: maximise applied learning and support, innovation for public health, develop globally responsible people and organisations, again consistent with the Charter, and strengthen Wales' global health approach. So again, pulling from the Charter, learning that, and trying to get this integrated into what the whole of Public Health Wales is doing. In terms of some of the key objectives, strengthening and developing existing and national and international networks and partnerships, change and innovation, so facilitating sharing, research, knowledge mobilisation and communication for change and innovation. Establishing a reputation, I'm going to go on to that, as a world-leading public health agency, so making sure we're working with the right people and have the right sorts of credentials to work, and increasing national and international visibility. Governance and coherence, so ensure sound governance, again what we're doing is proper, strategic alignment and added value from international activities. And the final two, the capacity and sustainability, so supporting and building that capability through training, income generation, and commercial opportunities, and the cultural part, promoting a culture of global responsible citizens, enabling a forward and outward looking approach. And if people want it downstairs, they can get a copy of this, as well as the Charter as well, which is downstairs on the table. So examples, and I think this is being talked about this afternoon, and in the middle of there is Rhiannon Bowman-Woods, our Director of Nursing. Again, there'll be a lot more on this, but things we're at least feeding into, together helping deliver for Uganda's nursing strategy in line with WHO global strategic directions. strengthen the skills and experience, sharing skills and experience to strengthen capacity and support nursing leadership through an agreed, again, education programme. And again, I think that's being talked about more this afternoon. What I want to move on to is how some of our work can be, if you like, amplified and used on an international basis, and also how we learn from an international basis. This is a piece of work we did called Making a Difference. Making a Difference was really a look from a return on investment basis on what works on public health. And it was presented like this, as well as in longer reports. So this is addressing inequalities in Wales. Simple, straightforward information telling you what inequalities look like. And then on the other side, what the solutions look like. And there was a large textual document behind this for people who are interested in the information. And Making a Difference included one on inequalities, alcohol, smoking, physical exercise, early years, obesity and diet, mental health and violence. And it was a relatively novel approach because it was looking mainly from an economic basis, which makes a powerful argument, and again trying to make sure that the information was easily accessible. So based on that, we're now working with the World Health Organization, who were interested in this, to do a European or an international version of that particular document. Investing for health and well-being, again the return now on the social return on investment for public health policies, supporting and implementing the Sustainable Development Goals. And again, similar sort of approach, but now amplified at a higher level. Based on the principles within this document when it's launched later this year, business as usual is unsustainable because the costs to individuals, families and communities are just too high, and for the planet as well. Investment in public health policies is an effective and efficient and innovative solution to some of these issues across the whole sustainable development agenda. And an investment for health and well-being is a driver for economic growth, as well as economic growth being a driver for health itself. So taking these from what we've done in Wales, and I'll come on to that as well later. Another little example of learning is just contributing, and this is a piece of work we were involved in, which was run across, I think, 8 African nations: Ethiopia, Kenya, Tanzania. I won't go through all of them, Lesotho, Angola, there was a couple of others as well. But here, looking at a number of areas where we have some expertise. So, as well as infectious disease, gender-based violence and alcohol, and very much in these different countries, these 3 things were looked at as different issues. But of course, they're not. There's a massive relationship between gender-based violence, how that impacts on things like HIV transmission. There's also a relationship between alcohol and how that affects both gender-based violence and things like HIV transmission and things like medication. So we were working with UNDP and WHO, supporting this particular piece of work, looking at how we can bring together infectious disease, gender-based violence and alcohol into overlapping policy areas. And the outcome of that particular piece of work, where there were policy people from all 8 countries, was to support developing a roadmap to guide policy change over the next 12 months in each country. Alcohol is another important issue, and we have been working in a variety of settings with people on that. And I think for people who aren't aware, although it may be at the moment that alcohol consumption is higher in Europe than any other region in the world, there's no doubt that the highest growth areas are in Africa, and you can look at that even in things like this, which is taken from the alcohol industry literature. While Asia will boast the highest consumption level for beer in the coming years, Africa is set to provide the strongest drivers for growth according to recent research. So very much being targeted by an industry which has grown, particularly on a European and an American basis. And it's important that we're working with people about the lessons we've learned in terms of stemming some of the problems, which are going to be amplified considerably if they're not tackled in those particular countries. And looking at things like outlet density, which we know, closing hours, some of the basic stuff, pricing, promotion, regulation, but also bearing in mind what we can learn and what we don't know. These are some pictures from when I was working, looking at the situation in Kibera in the slums, and about the illegal alcohol market, which makes up a massive proportion of alcohol in those particular places, and needs us to learn and look at different approaches, and not just think the ones we explore are going to work in those places. So, £5.40 per day for every person in the world. That's the cost of something. I'm going to say what it is, but just before I do, it's $14.3 trillion per year, or equivalent to 12.6% of GDP. It's one of the largest barriers to economic development in the world, and it's violence, and it's something that I and some of the team here work on. If you just get a 1% reduction in violence, you can get up to or above a 0.25% increase in GDP. Not always seen as a public health issue, but a huge public health issue in terms of, if you think about trying to get people to work in areas. People have talked about insuring individuals in this session, even here. And some of those issues are about, can you actually safely work in those areas? And even afterwards, can you establish a workforce in those areas when the workforce there, if it's mobile, wants to move away? So don't underestimate violence in terms of the broad impact it has on health and all public health issues. This is from WHO. 30% of ever partnered women have experienced physical or sexual violence by an intimate partner in the world. About a third of all of them. Southeast Asia and the African region are highest for intimate partner violence. And why is that a public health issue? Well, amongst other things, if you're a victim of intimate partner violence, you're about 16% more likely to have a low birth weight child. You've got a 50% increased risk, as why we were working on policy with people, of contracting HIV, 50% increased risk of syphilis or gonorrhea, 100% increased risk of having an alcohol problem, again, back to the policy stuff we were talking about, 100% increased risk of depression, and 350% increased risk of attempting suicide. So, massive health issues, which we don't necessarily think of as part of the violence equation. The same is true of children. 54% of children have been physically abused in some way or other in the last 12 months globally, about 50% in Africa. An enormous number of individuals. 1 in 5 girls have been sexually abused during childhood. Yes, places like Kenya, two-thirds of women aged 18 to 24 have been experienced physical violence as a child. But even in our own studies here on adverse childhood experiences, about 17% of adults were physically abused as children in Wales. So we don't have all the answers, and these are questions which need to be answered, certainly on an international basis. We've been doing a lot of work on ACEs in Wales, but in other countries as well, so adverse experiences in childhood. And just to say what they are, they're things like physical abuse as a child, verbal abuse as a child, sexual abuse, emotional abuse and neglect, and then things that children are experiencing because of what happens around them in the family. Intimate partner violence, mental illness in the family, alcohol abuse, drug abuse, parental separation or incarceration, so a major problem in the family with criminal justice. These together we call ACEs, and the more of those you have, the much more chance you are, almost no matter where you live, of experiencing some very poor health outcomes. This is a piece of work we haven't published yet, but this is a global analysis of the impact of poor childhood, which we've done with the World Health Organization on a range of health conditions. Just to give you an example here, people who've had 4 of those ACEs in their childhood compared to none, these are some of the outcomes. They're twice as likely to be heavy smokers, they're twice as likely, 3 times more likely to be heavy alcohol users as adults coming down here. They're nearly over 5.5 times likely to be illicit drug users as adults. But some of the things we think of as not as typical diseases you might catch, non-communicable diseases, they're twice as likely to develop heart disease. And I haven't got time to go into why. 3 times more likely to develop respiratory disease. And down the bottom here, they're also sadly more likely to commit ACEs themselves. 8 times more likely to perpetrate violence in the last 12 months. 30 times more likely to try and commit suicide. So this is a cycle which is on an international basis, as I said. This one's a global meta-analysis, trying to inform how violence is impacting some of the health conditions we don't necessarily associate with that on a global basis. And before we think again, we've got the answers. This is the level of people with 4 ACEs in Wales and England, about 10% of people in the population. And this is the level of ACEs with 4 or more ACEs in South Africa in adolescence, about 10%. We've released a video which people can watch. It's at aces.me.uk, which tells people more about that. We haven't necessarily aimed this internationally, but we're very pleased that this is a Dutch version already available. No one told us they were making a Dutch version, but if empowering women is something that's often about domestic violence prevention, but it's also part of the story in the counter-narratives around violent extremism. And with vulnerable groups who we work with all the time, there's a question about which sorts of people have access to them. So if you take prison populations, refugees, or those with ACEs, do they have access to people who are positive coaches and role models, or do they have people who are preaching and brokering hate? And these are things which we need to think about in terms of our populations and the populations with partners we're working with abroad. The evidence base around this is in its infancy, but it is something that we're slowly trying to take forward. It's important as well for people who may be, if you like, not exposed abroad, but in this country, and this is a piece of work from some years ago, but even on the only global survey we have in this, even some years ago, just over 1 in 4 people stated they'd been a victim or knew someone that had been a victim of terrorism. At that stage it was about 10% of the UK. It's considerably higher, I would suggest, nowadays. So, when we're thinking about peace and health, and this is my final one, about 7 billion people globally, and this is one of the issues for violence. We're often thinking on an international basis about things like this: 4.5 billion people having access to a working toilet and basic hygiene. In the meantime, creeping up behind us, 6 billion people have access to a mobile phone, more than have access to a toilet. But have we really thought through what the public health consequences of that are? What's being communicated, what information we are communicating to people, how those things are being used, how we should get our own messages and our own narratives into that system. We have the Sustainable Development Goals, which have actually been, in many ways, we've been looked at as Wales as world leaders with the Wellbeing of Future Generations Act. And finally, in the pipeline from the things that we're involved with in Public Health Wales, we're working with the WHO now, hopefully putting together a work programme looking at sustainable development, and us working much more closely on a 4-year work programme with them, looking at social and economic environmental factors, tools to build capacity and capability for health and well-being. And they also want us to look again at what we can do to support other people with the transmission of public health information in the same way that we did with making a difference. And specifically in violence prevention, we're working with WHO on toolkits for violence prevention in schools, and hopefully that will be launched or used at least later on in the year in Africa. And also, we're also working with them on developing vYnfo, which is a global intelligence tool for violence prevention, and looking at what the second global status report on violence would look like, funding hopefully being available with WHO. So that's a short insight into some of the things that are going on, and thank you very much for listening.